Now we have time for our discussion and question forum. I'm going to ask the speakers from the last session to come up here to this table here, and we will take questions from the audience. I was going to propose some topics of discussion, but I think there are people who are anxious to ask questions, so we'll start with that, and we'll take it from there. This morning, just to refresh your memory, we heard about making the killers pay. We heard about Breast Health Day. We heard about colorectal cancer screening in closed communities, HPV vaccination campaign in local pharmacies, cancer prevention in the corporate setting, and our European Week Against Cancer Youth competition. So if you'd like to, I'm going to stand over here because I think we only have, is there one, are we enough? I can stay here, that's fine. Okay, so if you'd like to raise your hand and address your question to the person with whom you'd like it to hear from. Thank you very much.
Thank you very much. I'm very glad that we're in Rome, where there is a forum, and that this is an open forum. So forgive me if I reduce the celebratory atmosphere at the end of the last presentation, but I do think that what was said by my learned colleague, Professor Stockbrugger, needs to be challenged. The notion that colorectal screening in closed communities, as he advocated, should be pursued so aggressively as he suggested, I find astonishing. In the first place, it directly contradicts standard European Union policy on colorectal screening, population-based mass screening, which has been established on the kilograms, I think he said, of evidence that he appears not to want to refer to. And the opportunistic character is directly opposed to mass screening. There is no sense in which such programs can be evaluated and monitored for their efficacy and safety in the same way that mass programs can be. And the characterization of mass programs as slow in comparison to the Ferrari, I would disagree with. They're not slow, they're appropriate, they're measured, they're based on evidence. Opportunistic screening leads to greater inequality in access to diagnostic tests and therefore treatment, and not the opposite. And I find it astonishing that someone standing here, apparently representing as many as 30,000 gastroenterologists from across Europe, should espouse the joint imagery of a Ferrari and ostriches with their heads in the sand. And I think the association of at the end of the speech with this unity of European gastroenterologists with the Ferrari is misplaced. I think they're the ostriches, and it's the mass screening programs that are the Ferraris. They're the quickest and most effective way to reduce the burden of this disease.
You didn't give your name.
So sorry, I should have done that. Michelle Coleman from the London School of Hygiene and Tropical Medicine.
Yes, good, thank you. I'm very glad for your comment, and it would take a long time, and possibly we could also sometime discuss together. I like to have this critic on it, because certainly I personally have thought long about that, and not everything I was saying was said on behalf of the UEG, but the UEG has been chosen me to speak here and in other places because they have understood that I have got a long experience, and an experience which is wider than only concentrated on population-based screening. Many things, many critic points you have been taken belong to misunderstanding. I am an advocate of well-organized and effective population-based screening, but, and that is what I was showing in my slides, these well-organized population-based screening with a Bible of recommendations to it, which I showed here, and which I'm very proud and glad, because the UEG has been co-working heavily in that, has not led to that a union as rich as the United States has been able to do what they promised to do in 2003. And there are many, many countries, and I showed you the countries, where that has not happened. Certainly the British, the French are very happy, the Italians are half happy about it. The Germans are very happy about their opportunistic screening because that has covered so far more than 3 million people, has reduced mortality, is better evaluated than any other population-based or any population-based screening. You certainly have read the articles by Brenner recently in Gastroenterology, where the whole program was described to its effects, to the economic, the health outcomes, and so on. So I think that certainly if you have got a ideology and have to follow it and then you will always find something wrong with people who are doing something else. But I told you in the end where I would recommend it. And I think that the situation in Europe should not be like it has been in Holland until this year. Holland is one of the richest, best organized countries regarding its health care and its care for its people, and it has been impossible until the 1st of something in this year to get a colorectal cancer screening because it wasn't any law. I myself had people who were coming to me and saying, Doctor, you have been working in that field of colorectal cancer screening. I want to be screened. Where can I go? Nowhere. It didn't exist in the Netherlands. Then they said, I come back tomorrow, and they complained about symptoms or blood in the stool or whatever to get their screening done. So that is the situation of Europe, and therefore I'm advocating for, as we not are having a good program anywhere, start somewhere and give people who are well controlled, who are honest and ethical as doctors should be, to set up a program like that. That is my message.
Okay, I have another question here from this lady. Just one moment now, the microphone will come to you.
All right. Thank you. Hildron Sunset from the European Institute of Women's Health. Very interesting examples of best practice. And I have, first of all, one suggestion to make, and then I have a specific question to Rute Horta. So the general suggestion I would like to make, I really like the example from Europadonna. I like the Ligue contre le Cancer, and also the pharmacist proposed immunization program in Portugal. And as a European organization that champions women's health, I would very much like to have a link to your programs on our website to give it, to highlight what is happening. I suggest to the organizer, perhaps this could be possible. We could share the links. Now my question to Rute. I really like the program where the pharmacists do the vaccination, are involved in the HPV vaccination in Portugal, because as you said, the pharmacists are very close in touch with the general public. Now, I noticed in your presentation that you did very well reaching out to the educated people, women, girls with university education, obviously 50% coverage. And I wonder if you have any plans how to reach out to the groups we are most concerned about, because every one of us who is educated has a much better chance in life to get access to what we need, what is required from us. But how do we reach out to the groups that are women that are more disadvantaged? Have you got any plans to as you are in a pharmacist, you're clearly much closer connected to the community, because I think this is where the real lack is. But otherwise, I really like your program. Thanks very much.
Thank you very much for your question. For women, you asked if we have plans for disadvantaged women. We have not plans for that women. We have plans only to campaigns in information about this disease and the benefits of immunization, but not to that kind of target people. No, sorry, I have no answer for that question. Thank you.
Nadia Segnan from Center of Cancer Prevention and Cure in Italy. I have a question for Susanna Leto. You are offering a screening test, for instance, ultrasound and physical examination for the breast, for which there is no evidence of effectiveness. And I'm wondering which is the rationale for doing this. But my another question is the employer able to know the result of this type of examinations, apart what is in the law for employee?
No, in the sense that we receive a personal report from enclosed envelope. We receive a personal report. In terms of ultrasound, I cannot reply. It was decided this year to add this ultrasound. It was proposed by the league. So these oncologists came with this portable ultrasound. So I don't know the reason why.
Any other questions? Yes, down. Oh, sorry, we're here first, and then I'll come to your question. Thank you. In the front.
Yes, I really this morning I heard a lot of goodwill, but we must really consider that prevention program may be dangerous, and anytime we promote something that has not proven efficacy, it may be dangerous for our health. So everything we do, we must ask: Are we sure? Are we sure that it's serious to recommend a PSA test at 45 years of age? Are we sure that what we are recommending as healthy food? I have the example of the Italian League Against Cancer. They produce a leaflet on healthy food, but I would have recommended that first read what WCRF has written in the report, in the 2007 report. We must be very, very careful in promoting preventive activity.
Yes, we would like some. We're just going to comment to your question there.
I just want to comment that, yes, I think we have to be extremely careful. Certainly our organization, Europa Donna, did not embark on a prevention campaign until there was a huge amount of evidence from the International Agency for Cancer Research indicating particularly those areas of physical exercise, maintaining a normal body weight, avoidance of excess alcohol, etc., with an actual description of what you need to do. And I think we do have to be careful that we don't think that we can prevent all cancer this way and thereby perhaps provide less service for cancer and for the treatment of cancer, and for implementing the European guidelines for quality assurance in breast cancer screening and diagnosis, another very important priority for our organization. It is important that the correct best practice service be provided to people for these diseases, and that we certainly can't rely on prevention to take care of all of cancer. But it certainly is an important area, as I think we all recognize today.
Hello, my name is Annemarieke Rendering. I work for the Ministry of Health in the Netherlands. I'd just like to respond to Professor Stokbrugger and his comments on the Dutch screening system. I think the Netherlands have a very good reputation when it comes to screening programs for the breast cancer screening, cervical cancer screening. It's existed for years, very well monitored, very well organized, and we're very careful in what we do in our screening programs. We have excellent pilots, we have all the evidence, and then we start and we roll out very, very slowly but carefully. There were some pilots in Holland that were very good examples for the rest of the world. We've got some good evidence. It's available as well. I've sent it to the APAC before. And anybody who's interested in objective information about the Dutch screening programs, I'd be very happy to help. Thank you.
If I just may respond to you, I am grateful for that you praised the system. I was part of the setting up the studies. It was well done, but it was done too late. It has been discussed. No, it has been discussed for a long time. If you think when France was starting, when England was starting, and Netherlands are a rich country, so they could have started earlier. But there were disappointment with some of the previous studies, and that is what the colleague down here was saying. If you have got doubts, it might take longer. We thought as gastroenterologists that it was taking too long for the government to decide for colorectal cancer screening. But it was very well tested on beforehand. You are completely right.
Another question in the front, and then another question
down here. It would be a comment. Huh? I go back 25 years ago, what was said now. You need a serious committee of cancer experts that will make consensus building either conferences or diagnoses. I share some of the comments that have been made because 25 years ago, we had no doubt, not so much doubt on healthy living. The first European code was very cautious about fruit and vegetables, about fat intake, and so on. But there was a major epidemiologic studies called the EPIC studies that has involved indeed 400,000 people, I guess, in Europe, with blood sample taken and frozen to really get convincing evidence. So I guess that now the code on the lifestyle issue is really safe. Where the code and the discussion we had here is still unsafe is on screening, benefits, and recommendation. So I would say, remember, I am not an oncologist, I am an economist. What really should be done again is to have a type of consensus meeting among oncologists to agree whether this type of screening is really benefit. On the PSC issue, as a normal citizen, I read newspaper. I understood it exactly that there are some questioning about the PSA, measurement and conclusion about prostate cancer. I mean, all this needs to be sorted out by experts in cancer matters. So what I will advise is that this forum, this partnership against cancer, has the support of a committee of cancer experts well chosen around Europe. That will be one of the recommendations I will make from the discussion we had. Thank you.
My name is Karen Budewig from the German Federal Ministry of Health. Just another question for Dr. Stockbrücker. What exactly did you mean by Germany is very happy with the opportunistic cancer screening for colorectal cancer? I'm sure you'll be aware that one of the objectives of the National German Cancer Plan is to introduce organized population-based cancer screening for colorectal cancer.
That was obviously not possible 2002 when the gastroenterologists pressed for screening. So in the end they took it in their own hands, if you might remember, had a big campaign with a big adhesion to it, and in the meantime, and that was supported by the government, and in the meantime that is well evaluated. And the figures I mentioned already, I won't repeat. And so far, we have got a lot of German and outstanding German gastroenterologists in our association. They are pleased with what they have reached, but they know if they do colonoscopy population-based, it will be even more efficient. And that is what they are doing now. But obviously, time then was not ripe. But in the meantime, I think it is 50,000 lives that have been saved. So that is not little.
We have another question here, the man in the white shirt.
Reinhold, as a gastroenterologist and an epidemiologist, I don't completely agree with you. What is very important in a screening program is really to have a demonstrated effectiveness and to have consensus data. And I remind you that at the moment, the EU has published in the official journal of the Europe a recommendation concerning screening and in particularly colorectal cancer screening, and they consider that at the moment, it may be changed in the future, that only fecal local blood test was a recommended strategy. And I think that we have to remind that compliance is a very important objective in mass screening. And most of the time, with opportunity screening, you have a 2-hour participation. Some individuals will benefit from it, as you have said, of course, some individuals. But if you stand from the public health point of view, from the Ministry of Health, for instance, you want to see a major change with the money involved in the screening program, and it can be achieved only if the compliance is high enough. For instance, in the Netherlands, where I agree that some very interesting pilot studies have been done, it has been shown in a randomized study that with immunochemical test and the participation of 60%, you find more colorectal cancer than with sigmoidoscopy and the participation of 28%. So when the participation is too low, you don't change the results. You have no effectiveness.
Jean, I thank you very much for your comment. We are both running on this line parallelly for a long time, and we can always be pleased with what is achieved, and we can shut our eyes for the dark holes. And as I spoke to you before the discussion here, the French program, which is one of the best in the world, like the British, has a range of participation in various regions from 20 to 55%. And also the best acceptance of 55% for me is not enough, because there are 45% lacking. And if then companies like BASF, and that might be Renault or Citroën or whoever, says, listen people, we have got this program, you were not adhering, we give you a benefit in our company for if you adhere to that program, which is the national program. Why should that be forbidden? That is opportunistic in its best sense if it contributes to the existing program. And exactly that is what BASF was doing in Germany, in an existing possibility where every German above 50 has free access to colonoscopy. There is no undemocratic way in it. It is all paid by the insurance company, which is reimbursed by the government. If their BASF is saying, listen, obviously you haven't been screened yet and didn't want to do, listen to our information, we help you to that, and we do it. And then about 30% of people who have not followed the government offer do the screening anyway. So that is a complementary, opportunistic thing. And that, I think, is useful.
We have another question down here. I think that might be the last question, if that's all right.
Well, a question or more or less a comment of all these interesting discussions. I'm Tito Albert from EPAC. I have to say that I'm really concerned. I share the opinion of Professor Coleman. We have some bad experience in Slovenia. We had at the beginning of the, I would almost call it frenzy for opening mammographic centers. What happened? There were women, mammographic screening was offered to women who were too young, were just basically exposed to radiation, and recall rates were huge. They were 15–20%. So we have to know, as it was said before, what we are doing. Currently, now even urologists are struggling against PSA screening. We know that Rotterdam's study was inconclusive on PSA as a tool for screening. And we have companies that offer reimbursement, I mean insurance companies that offer reimbursement to their insurees for this. So we have to be very, very careful how we advocate it. And I sincerely, from the equity point of view, cannot accept that a rich, enlightened company will have its employees screened at 100%, and those who don't have the luck and the luxury to be employed by such a company will have no access because there is no national screening program. So personally, I cannot be in favor of that.
I would like to comment and agree, and also mention once again, we have a consensus of experts. We have European guidelines on screening for mammography, on screening for cervical, and on screening now for colorectal. And there's all kinds of opportunistic screening that absolutely is deleterious and not good, certainly for women. And that's the kind of example that we had many years ago before we had these guidelines and before we started advocating that these population-based mammography screening programs are the ones that should be implemented according to EU guidelines. I'm sure that's the case for the other cancers, though I don't know as much about it, but I couldn't agree more that it's important that we follow the guidelines that have already been set down and that have been agreed upon by experts. It's not as if we need a whole new group of experts to get together again when we already have guidelines for these three types of cancer.
No, I would like just to comment about the Italian situation. So in Italy, there are already several screening offered. In terms of breast cancer, we offered counseling to all age women, so even young women. So in terms of good habits, good health habits. So I don't think that we are doing a privilege. We are only taking care of our employees and giving them some advice.
Okay, so Dr. Stuckberger here is just going to make a last comment. Thank you.
Yes. Once again, I think my answer to the last comment would be very similar. I just give you, we are in Italy. I love this country. I live here. And I would like to do everything I can for that. If you are living here in the south of Italy, in certain areas, there is no screening established there. Where are you going then? Try to go to one of the northern states and to be screened. It might be difficult, or you might not be asked. So that is where I say that if people could, for the time being, offered something which gives, if they are aware of the necessity to be screened, which gives them a chance, then that would be very good. I see Dr. Senjan already starting to comment on that.
Yes, if I can, as a member of the National Observatory of Screening, is not true what you said about the situation in Italy. For colorectal cancer screening, in the 2011, we screened 1.8 million of people. And so this is one of the highest proportion at population level of screening in Europe. About the southern Italy, there are some regions that are not able to implement effective screening program. But this is a problem, a political problem, that I don't think can be solved introducing some spontaneous activity without rules and without quality indicators and evaluation and monitoring of screening. So I don't think that your recipe is able to solve the problem.
There is no recipe, it is a suggestion, an idea.
Of course.
Yes, and I wouldn't say that we here shouldn't applaud for the American and for the German and for the Polish system, which were forerunners and effective. So just to be blind for what is happening around and not even starting to analyze because one is very, very sure about oneself, I think is myopia.
Okay, now this is definitely the last comment question.
Henning from Eurocolon. We advocate for screening as far as we're able, but the economic climate is cutting back to such an extent that we are finding it impossible. And the other problem is, if you find the cases, how are we going to treat them when there's no money for drugs? And in some countries in the EU, we're not even getting generic 5-FU. So yes, hooray for screening.